Good morning. We're so glad that you took time today to join us and be with us. Welcome to Health Equity Through the Cancer Lens. My name is Deb Dillingham. I'm the Senior Director of Cancer Control Strategic Partnerships for the American Cancer Society in Ohio and West Virginia. It's my pleasure to welcome you to today's event. You should see a poll question popping up on your screen momentarily. And we would ask that you would just take a moment to let us know where you're joining from today. We'll have a few polls during our forum this morning, and we would ask that you would just take a few minutes, let us know where you're joining from, and then we'll begin our forum. So we'll give you just a second to make your selection and hit submit, please. While you're doing that, I'll give you just a little bit of housekeeping. We ask that if you've called in from a phone line this morning, that you please enter your name and organization in the Q&A so we have record of your attendance. We want you to know that all lines will be muted during this program, and we ask that all questions be entered into the Q&A box. If we don't have time to answer your question live during today's forum, we will ask our presenters to respond to your question post-event. Now let's get started. I have the pleasure of introducing to you Marianella Napolitano. Marianella is currently serving on our area board for Ohio, Northern Kentucky, and West Virginia. Originally from Ecuador, Marianella moved to the United States to pursue her undergraduate degrees in information management systems, nursing, and an MBA in healthcare administration. She's been in the healthcare field for over 15 years, working with providers serving vulnerable populations. In her current role as Regional Director of Clinical Transformation for Value-Based Programs, she leads a team of transformation consultants in Ohio and Michigan, whose role is to support safety net providers in their journey to provide value-based care. She's been recognized for her efforts to reduce health disparities and her ability to work with diverse clients, members, staff, and leadership at all levels of the organization. Marianella resides in Cleveland and was recognized as Crane's 40 Under 40 in Cleveland in 2019. Welcome, Marianella. We're so pleased you're with us today.
Thank you, Deb. Good morning, everyone, and thank you for having me. It is an honor for me to be here, as I'm extremely passionate about this topic. If you could please advance to the next slide. Thank you. So before we get started, I'd like to thank our sponsors, the James, the Ohio State University Comprehensive Cancer Center, Anthem Blue Cross and Blue Shield Foundation, the Harry C. Morse Foundation. This program is supported by the Ohio Partners for Cancer Control and Mountains of Hope and Comprehensive Cancer Coalitions. A special thank you to Dr. Sherry Young for being our AAFP provider liaison for CMEs. And if you could please advance to the next one. So thank you. Like I mentioned earlier, I'm honored to be here today to introduce to all of you the H.E.R.O initiative. H.E.R.O stands for Health Equity for Research and Operations. And what that means is that in order for us to be able to achieve our mission of decreasing cancer mortality by 40% by 2035, we need to be able to touch every community impacted by cancer while actively working to end cancer disparities. We know that cancer affects 1 in 3 Americans. I'm sure everyone in this call knows someone that has been impacted by cancer. And while it can affect anyone, it doesn't affect everyone equally. There are social determinants of health, from where you live to the type of access that you have, that will impact a person's battle against cancer. To the American Cancer Society, health equity means everyone has a fair and just opportunity to prevent, find, treat, and survive cancer. And while this initiative is new, ACS is not new to the fight for health equity. We've been doing this since the early 2000s. In fact, we have several research grants supporting health equity. And while we have done a lot of work related to health equity, there's much more work that needs to be done. And that's the reason why ACS created the H.E.R.O initiative, because we have done work before, but there's much more to be done, and we cannot do it alone. We're going to need all of you to support this effort. So I'm honored again to be here to formally present to you the H.E.R.O initiative, to launch the initiative presented by United Healthcare. I'm passionate about the topic, but I'm also very lucky that I get to work for a company that prioritizes health equity. So the campaign, what that means is that we're going to be recruiting for ambassadors, for people within the community that are committed to support health equity efforts. So if you are interested in learning a little bit more about the initiative, if you want to know more about it yourself or know somebody that may be interested in knowing more, feel free to reach out to myself or any of the ACS leaders on the call. So thank you for having me here today. Excited to talk about health equity, and I believe I will pass it on to you, Deb.
All right, thank you very much. If we could, there we go. Let's review our agenda for the day. As you can see up on your screen, we'll begin with our health equity screening panel, comprised of presentations by Chastity Washington, Dr. Erica Trappel, Rev K Albright, and Dr. Angie Settle. Then you'll have a chance to learn some best practices in lung cancer screening from our partners across West Virginia and Ohio. Next, Tracy Wheat will share some tools and resources available to you from the American Cancer Society to support health equity efforts. Then you'll have a chance to learn more about the work being done with the American Cancer Society's Cancer Action Network. And lastly, you'll have an opportunity to view the American Cancer Society's brief health equity video before we conclude today's program. Next slide, please. Okay, let's talk a little bit about today's CEs. The American Academy of Family Physicians has reviewed Ohio, West Virginia Virtual Health Equity and Cancer Forum and deemed it acceptable for up to 2.0 live AAFP prescribed credits. You will receive a certificate to claim your CEs following the completion of today's post-event survey. Our objectives for today's event can be seen on the current slide. Please note that the Planning Committee members and speakers have declared that there are no relative financial arrangements or affiliations with the organization that may affect balance, independency, objectivity, or scientific rigor for the CE event. Also, please know that slides will be available after the presentation and that this event is being recorded. Now, it's time to do another poll. We would love to know what state you represent. You'll see that pop up on your screen here. And if you would just take a moment to let us know what state you're joining from, we would very much appreciate that. We'll wait just a moment. I'm sure our poll will launch. There we go. Oh, it looks like we have our polls in a different order. Forgive me. So this one is, what is your role or sector as it relates to cancer? Please describe your relationship. And if you would make your selection and hit submit, that would be perfect. And we'll give you just a moment to do that. And then I have the pleasure of introducing our first speaker. I'm going to go ahead and get started with that. So our first speaker, we're so pleased to have with us Chastity Washington. Ms. Washington is the director for the Center for Cancer Health Equity at the James Cancer Hospital and Solov Research Institute at The Ohio State University Comprehensive Cancer Center in Columbus, Ohio. The primary goal of this department is to work for health equity and cancer care for Ohio residents, with an emphasis on reducing cancer health disparities in minority and underserved communities. Ms. Washington has been with the center since 2002 and previously served as the department's program director. In this role, she helped to secure grant funding to provide free cancer screenings and other services for patients, as well as conduct population health studies related to cancer, clinical trials, and recently, COVID-19. Ms. Washington.
Good morning, and thank you everyone for inviting me and allowing me to be a part of this wonderful program. It is my pleasure to share with you a little bit this morning about health equity and breast cancer and some of the programming that we have done at the Center for Cancer Health Equity. Next slide, please. Oh, and next slide again. So I'm pretty sure I'm preaching to the choir when I share some of these background statistics. We know that breast cancer is the most commonly diagnosed cancer in women in the United States. It's also the second leading cause of cancer death behind lung cancer, and it attributes to a lot of deaths that we definitely don't need to have if we can get women in for appropriate screening and timely diagnosis and treatment. Next slide, please. However, we know that there is a subgroup of women that experience health inequities or racial disparities when it comes to breast cancer. In particular, African American and Hispanic women tend to have a lower incidence rate for breast cancer. So in general, African American women have a 1 in 9 lifetime risk compared to the general population's 1 in 8 lifetime risk for developing breast cancer. But when they do get diagnosed with breast cancer, it's often at a younger age. They're often likely to have a later disease stage, and when they present with the cancer, they tend to have more aggressive tumor types, and then both Black and Hispanic women tend to have triple negative breast cancer more often than other women. I think the most shocking and important statistic that we have is that even though African American women get breast cancer at a lower rate, they do die at 41% higher rate than their non-Hispanic white counterparts. Next slide. So why is that? It's a multifaceted, multifactorial reasons, right? So some of them include racial identity and racism. So not just being of a different racial or ethnic group, but the racism that is experienced. Oftentimes we have language barriers, geography. So depending on where you live and what access you have to services, including rurality. So the map of Ohio, we do have a large rural and Appalachian area that they not only don't have hospitals in some of those locations, they do not have mammography facilities. In addition, social determinants of health that include access, and I'll talk about that on the next slide. Genetics, right? So 10% of breast cancers are tied to genetics. And then we know that racial and ethnic minorities tend to access genetic counseling at a lower rate and then participate in the benefits from that counseling in a far lower rate than their white counterparts. Again, access is not just to screening, there's access across the continuum. So again, if we take the mobile mammography unit to a location, but they can't get in for the follow-up or the treatment, that is also a barrier. We know from the Institutes of Medicine report way back in 2002 and several studies since then that there also are disparities in treatment for racial and ethnic women. It could be simple as not asking them to participate in clinical trials, which we know are sort of the gold standard in care, right? So these are where our breakthroughs and our latest and greatest discoveries are taking place, but these women are often not included in those studies. Next slide. So what we've done to address these social determinants and these disparities in care is we have a Wayfinder patient navigation program that works with women across the continuum. So again, we work to address the social determinants of health. Our work is more downstream. So again, it's more immediately working with those determinants to get women in further care. However, we know that the most impact will happen if we look at advocacy efforts and work more upstream as far as getting people coverage and expanding Medicaid, Medicare, and those sorts of things. But our project looks at outreach education, providing links to services, addressing those barriers, particularly, like I said, access, and then other things that are on that social determinants that might prevent them from even considering taking care of their health because they've got bills to pay or they need to eat or those sorts of things. Next slide. So again, one of the evidence-based interventions we use is community outreach. We have community health workers that are from those communities. They live there, they work there, they worship there. They also speak the languages of those communities. They're really well trusted, so they can share that cancer information and encourage the women to get the screenings that they deserve. So we have staff that speak Somali, Nepali, Spanish. We have African-American representation. Prior to COVID, we were able to be out in the community doing a lot of events. We'd be at churches and mosques and community centers, adult daycares, you name it, we were there. During COVID, we were fortunate that we do have a project called Turning the Page on Breast Cancer that we were able to guide people to online so that they could do a breast cancer assessment, get a personalized risk, connect to a patient navigator, and then also have links to resources for breast cancer screening, as well as genetic counseling right from the comfort of their own home or on a computer or a web device. Next slide, please. So another key component is those partnerships that were mentioned earlier by Marianella, right? We work with not only our mobile mammography unit, we work closely with the Ohio Department of Health's Breast and Cervical Cancer Early Detection Program so that we can address the barrier of insurance coverage, right? Or the bill or the cost related to the mammography and follow-up, and heaven forbid, if they get cancer, they can get their treatment covered. We work with FQHCs and free clinics because again, they have a metric of getting their people screened. And we know that a lot of these women are seen at these facilities. We also worked with insurance plans, just again, getting their individuals covered, but then also having them at events so that we could help people get connected to coverage in the marketplace and other options for coverage. And then last but not least, we work with community agencies. So again, we want to be able to connect these women to resources for housing, for food, all of those different things. And by working with those community agencies, we are able to establish those links and get women in for those resources. Next. So again, we work closely with our mobile mammography unit. And mobile mammography units, again, they take the services to the community. It doesn't have to be a rural Appalachian area. We have women right here in Franklin County that can't get to a place because it's not on a bus line or they don't have transportation. They don't want to come to a big, huge academic medical center. So we could pull up right to the mosque or to the grocery store in their neighborhood, and they can get on and off in 15 minutes and get that service done in a location that's safe in a supportive environment. It was helpful during the pandemic because again, women did not have to come to a standing facility. They were able to sit in their car. What was their appointment time? They put their mask on, had their temperature checked. And again, we're in and out within a 15-minute time period. So we found that that was helpful during the pandemic, especially after the lockdown. And then we connect patients with patient navigation. Patient navigation has been proven way back with Dr. Harold Freeman, and then all of the research that Dr. Electra Pascal and others have done since then on patient navigation. They can educate the patient, they alleviate fears, they address the barriers, again, tied back to social determinants of health. In our project, we've had very few women lost to follow-up. We've had maybe 2 in the many years that we've been doing this. Most women are returned back in within 30 days, if not 60 days. We have a few outliers. So like 98% of the women that we've seen are back in for diagnostic resolution or treatment within 90 days, which we know improves their outcomes. Next slide. So these are the numbers, I'll say pre-COVID, but it is a little bit in the beginning of COVID. And we are on track again this year. We did have, again, some delays due to COVID. This year, between July and December, we were able to screen 458 women. But again, the first full year pre-COVID, we had 57 events where we went into different communities and screened 708 women. Of those, we had about 17.5% that needed to come back for follow-up. We were able to find 4 cancers. Again, the majority of the women we found were racial and ethnic minorities and underserved. They were out of guidelines. We used the 2-year reference because a lot of our women use the breast and cervical cancer program for their coverage, and they will only cover screening mammograms every 2 years. Again, we were able to enroll 347 patients in that program. And so if you're not familiar with that program, if women are enrolled, they get their screening services covered, their diagnostic services covered, and if they're eligible, they get what's called BCCP Medicaid that they can use like regular insurance throughout their treatment. We provided transportation assistance for 19 patients, and that was to come back for diagnostic follow-up, because again, we took the mobile unit to them, and now we expect them to come to us for their follow-up, so we did provide that. And then again, we do work with a lot of limited English proficient populations. So our staff were able to provide translation and interpretation services for 256 patients. And we were able to connect women, 148 women with medical homes, whether that be Ohio State or one of the free clinics that we work with, so that they could have a provider to receive the mammogram report, and then just a source of usual care. So with that, I will end my presentation and thank you for your time.
Terrific.
Oh, sorry, I did have one more slide, sorry. So again, just a quick summary. So as I mentioned, there are multi-factors influencing health disparities in breast cancer. They're at the system level, patient level, social, cultural barriers, and just being able to recognize those barriers and do something to address those barriers will go a long way, not only in breast cancer disparities, but other disparities. There's been studies that look at providing navigation as well as resources for housing and food that have shown a significant increase in health outcomes for patients, not only in cancer. And then I would just caution everyone that we know COVID-19 had a slowdown in screenings and also services. It picked back up, it's not where it needs to be. And we know that historically, those marginalized individuals are going to be the one that see the worst disparities because of the pandemic. So again, we're willing to partner with people, that you would help us advocate for navigation reimbursement. That is an advocacy issue that is in need of attention, because right now we cannot reimburse for navigation services through health insurance. So again, thank you.
Terrific. Chastity, thank you so much. We do appreciate you sharing with us and being with us this morning. Our next speaker is Dr. Erica Trappel. Dr. Trappel is the Associate Professor of Population and Quantitative Health Sciences and Director of the Prevention Research Center for Healthy Neighborhoods at Case Western Reserve University. She also serves as the Associate Director of Community Outreach and Engagement at Case Comprehensive Cancer Center. Dr. Trappel is trained in epidemiology with a focus on health behavior and statistical methodology. She has more than 15 years of experience as a leading principal investigator or serving as co-investigator on a funded research project, and has served as co-investigator on more than a dozen federally funded grants or contracts. Almost all of these have been executed with a community-based partner. Welcome, Dr. Trappel.
Thank you. I'm really excited to be here today. All right, so I'm going to be talking about prostate cancer screening and racial disparities we see in prostate cancer. And I just have to joke, many of my prostate cancer colleagues often comment on how prostate cancer advances follow right behind breast cancer advances. And so it feels quite appropriate that I'm following Chastity's conversation on breast cancer to talk with you all about prostate cancer. Next slide, please. Okay, and you can just, there you go, stop right there. So I have a history really over almost 2 decades of tobacco use work, and I've really come into my cancer screening and cancer prevention work in the past 2 years. And what I realized is that there's a lot of similarities, and I imagine that many of us on this call who do disparities work recognize that if we really dig in and keep asking ourselves, why do these exist, we all get to some of the same inequities. And so it's been really lovely to take my tobacco experience, tobacco disparities, and understanding those inequities and be able to apply them to prostate cancer screening, which is not something I thought I would ever tell you I'd be working in and excited about, which I think will come across today. Go ahead to the next slide. All right, so I like to start from the beginning, so I apologize if this is a repeat for anyone. One of the first things I needed to really do was understand the prostate and where it was. And so just sharing with everyone, the prostate gland is in the male reproductive system, located just below the bladder and in front of the rectum. It is really tightly tied in with everything right there. And it's about the size of a walnut. So it's a very small gland. It surrounds part of the urethra. And the prostate gland produces fluid that makes up part of semen. You can imagine being there, it is extremely difficult to get access to. So we have had to come up with other mechanisms of screening to identify potential prostate cancer. Next slide. So the numbers generally, there are about 249,000 new cases of prostate cancer each year and about 34,000 deaths per year. 1 out of 8 men will be diagnosed with prostate cancer. So this is the most common cancer among men aside from skin cancer. And 1 out of 41 men will die from prostate cancer. This is more than any other cancer besides lung and accounts for 15% of all cancer deaths. The average age of diagnosis is about 66 years. Now this is overall. Next slide, please. Okay. So I'm going to show you some data from Northeast Ohio, but I want you to know that these patterns are really similar across the country. And this is age-adjusted incidence rate. And I don't need you to necessarily look at the numbers necessarily, but the bright purplish blue bar, which is higher than anything else here, represents the age-adjusted incidence rate among non-Hispanic Black. It is higher than non-Hispanic white and all others for where I am in Cuyahoga County, for the catchment area served by the Case Comprehensive Cancer Center, for the state of Ohio, and indeed nationally. And if you click again, can you please, okay, thank you. And this is the mortality. So we see an increased burden of both incidence and mortality among our African-American residents here in Cuyahoga County, across the state and across the nation. So this is a truly significant issue that requires a lot of asking why. Where is this emerging from? Next slide, please. So I took my epi hat and put that on and said, okay, what are the known risk factors? So we know that increasing age increases the risk for prostate cancer. We know that there appears to be a family history and a genetic component of prostate cancer. And as I showed you, it appears to be more common among African Americans. And African American men tend to be diagnosed at younger ages. This younger age trend is something we just heard shared by Chastity. We know that healthy lifestyles broadly contribute to reduced cancer risk. And my question was, if screening catches disease early and early disease is more treatable, what are the current screening recommendations? Now, I'm sure it's many of you are aware that there is a bit of controversy around screening recommendations. And for me, being new to the space of prostate cancer, I really wanted to get up underneath and sort of understand what the screening recommendations were. Next slide, please. Okay. So there's two commonly known mechanisms to test for prostate cancer. The first is the prostate-specific antigen test. And the PSA, it's a protein produced by prostate cells, which keeps semen in liquid form so that the sperm can swim. So a simple blood test can measure how much PSA is present in a man's bloodstream. When a man has prostate cancer, his PSA level increases, which is why the PSA is used as a screening tool. But there can be other reasons for a high PSA, which is why that's not a final diagnostic and requires more. Also known is the digital rectal exam, where a provider palpates the prostate to assess size, hardness, and bumps through the rectum. Next slide, please. So I went to look, and I admittedly usually turn to the American Cancer Society first to see what American Cancer Society recommendations are for prostate cancer early detection. And what I noticed here was the second bullet, which indicated that age 45 remain at high risk, which includes African Americans and men who have a first-degree relative. I thought, okay, this is great. I'm getting an idea that 45 is really the right age. Next slide. But when I went to the USPSTF recommendation, I recognized that there was a recommendation for men aged 55 to 69 and a recommendation for men 70 and older, but there was no explicit recommendation for men under 55. And this seemed to really disconnect with the recommendations from the ACS. So I went to the reference that's up in the top, and if you click again, I found some really important information that I pulled out. The 3 large randomized controlled trials on screening predominantly included men aged 55 to 69. So there's inadequate evidence on starting at a younger age. And if you click again, based on the available evidence, the USPSTF could not make a specific separate recommendation for prostate cancer in African American men because there was inadequate data representing African American men in order to, there's no direct evidence demonstrating whether this is true. So because of a lack of participation in the randomized controlled trials that inform these recommendations, we could be potentially missing a recommendation to screen men under the age of 55 and to screen African American men earlier as reflected in the ACS recommendation. Next slide. So in 2012, the USPSTF gave PSA a D recommendation and recommended against the service. And the reason that this is important is because the U.S. Preventive Services Task Force is really the organization that physicians and health systems look to and payers look to for reimbursement for testing as well as practice recommendations. And so this isn't something that's in the control of a patient seeking services, but at the provider level. And there was a study showing that from 2012 to 2018, that there was a decline in the number of men who were seeking PSA, and that decline was actually greater for non-Hispanic Black men than for non-Hispanic white men, particularly among younger non-Hispanic Black men. So the very men who were likely at greater risk were less likely to be engaging in that screening practice. And those differences by race were driven by increases in localized tumor incidence among non-Hispanic Black men. So metastatic disease was actually rising across all groups, but localized tumor incidence was rising among non-Hispanic Black men. Next slide. So the recommendation did change in 2018. There has been an attempt to sort of revisit this, but PSA remains fairly controversial. And so in our community, we recognize that prostate cancer is a significant racial disparity, both in incidence and mortality. And our community advisory board at our cancer center said, we need to do something to address this. We recognize that African-American men have not been included in trials. We recognize that screening occurs in primary care, which is underutilized by Black men. So what can we do? Next slide, please. Thank you. So I grabbed my academic partners up here at Case Western Reserve University from across our School of Medicine, our School of Social Work, and our public health practice, grabbed our community partners who really have an understanding of the state of the community experience. And we said, let's build this together. Let's figure out what a solution might look like. Next slide. Okay. So we thought about our opportunities. One is an opportunity for earlier PSA testing. We know that screening and recommendations are largely informed by white cohort data, and Black men present with prostate cancer earlier in a later stage. So there's emerging evidence that a baseline PSA at a younger age is a predictor of risk for total and aggressive prostate cancer. So maybe instituting screening at an earlier age is a great opportunity for us. Next. Okay. There's also the opportunity to integrate germline genetic testing and generate polygenic risk scores using non-white data. Again, this has been underrepresented with minority data in this type of genetic research to date, and we've got to include a diverse sample in order to get polygenic risk scores and genetic testing data that's really reflective and informative for African Americans. We also saw an opportunity for cascade testing, where we test the first degree relative to also inform family members' cancer risk. And then you can see here, our third opportunity was screening in a community setting. We really thought about the role of trusted others and trusted settings, and recognized that if we want to reach men who are not seeking clinical care, we need to find the places where those men are gathering, and think about how we can deliver that service in a trusted place, provide non-clinical return of results, and establish a long-term relationship, not just a health fair one-time connection. And finally, our community said we need to have a comprehensive, streamlined, person-centric approach to fully support men that included a community navigator because of the social barriers that may prevent screening and appropriate follow-up. Next slide. So we happen to have a very active barber on our community advisory board who said, you need to be in my shop. Let's figure out how to do this. Barbershop efforts are not new, but let's make this work in our shop. So this is Mr. Waverly Willis, who has been a champion for our work for the past 2 years. Next slide. So we are in the process of getting ready to launch in the next couple of months a barbershop-based prostate cancer education and screening program, where we will provide training to barbers to serve as health education partners. We will have community navigators who will assist in scheduling PSA screenings at the barbershop, where we'll have monthly events. And then we're going to create a virtual screening clinic where we'll be returning results to men and then connecting them to the clinical navigation and to their preferred health system and preferred follow-up. We'll provide ongoing support to men for annual screening and hope that this will increase awareness of their prostate cancer risk, as well as get them into long-term care and more preventive care. Next slide, please. This is our community advisory working group. We've been meeting virtually due to COVID. This is not ideal, but we're still all there. So I just wanted to thank all of these folks in our working group. And I believe that's my last slide. I think there's just a Yes, thank you. I'm happy to answer any questions. I know I've gone through quickly, but here's my email, and I look forward to talking with any of you. Thank you.
That's perfect, Dr. Trappel. Thank you so much. We do appreciate your presentation this morning. Let me introduce to you our next speaker, Rev K Albright. Rev Albright is the Health Equity Outreach Coordinator for West Virginia Covenant House. As a part of her work, she manages a program called Dr. Rainbow. Rev Albright says that managing Dr. Rainbow has been a joy in her role to help the LGBTQ+ community have a reliable place to search for providers that know the needs of the LGBTQ+ community in West Virginia. Dr. Albright, welcome.
Hello, I'm Rev K Albright. Next slide. LGBTQ have racial disparities. They are many, but it includes like coming into the office and how they're handled, and they're not very welcome sometimes. So we developed a resource, Dr. Rainbow. As you can see, it has various home and about and coming out for health, finding a provider. Next slide. If you are any of these, you're welcome to apply or to send me your information, and I will get you on Dr. Rainbow. We believe in a holistic approach, and Covenant House is known for housing, ability to pay utilities, helping people with HIV and AIDS, and a food pantry, and health rate. We have a health rate clinic. So it's next slide. This is how you can do it yourself. Share our resource. If you or your office need training in LGBTQ, we can arrange for that, because we know that you are looking to fill the need, but some people are very hesitant to come to you. We can help you be more friendly. Next slide. This is just the contact info for me. You can contact me, and I will put you in touch, put you into our slide, our providers. Just need to give me provider, health, provider, what kind of health, who, that kind of stuff. So I can help you there. Next slide. And if you have any questions or want to talk to me, this is my contact info, and we would welcome anybody from West Virginia or Ohio bordering. We don't restrict it. So you'd be surprised that LGBTQ+ individuals are willing to drive to have a nice, friendly provider. So contact me if you are that nice provider. Thank you.
I love the way you wrap that up, Rev Albright. Thank you so much. We appreciate it. And you'll see in the chat that you're getting requests for contact information. So thank you for being with us. We do appreciate it. Let me go into our next presentation. I'd like to introduce to you the final speaker of our panel this morning. This is Dr. Angie Settle. Dr. Settle is CEO of West Virginia Health.Right Incorporated, the state's oldest and largest free and charitable clinic. She has been a board-certified family nurse practitioner with the clinic for nearly 25 years. She holds a bachelor's degree in nursing from the University of Charleston, a master's as a family nurse practitioner from Marshall University, a doctorate in nursing practice from the University of Alabama, and she's completed the nonprofit leadership program at Harvard University's Kennedy School. She's dedicated her entire career to helping ensure access to care for underserved, uninsured, and underinsured West Virginians. In the summer of 2021, she, along with key members of her staff, helped start the EquiHealth Program for free, comprehensive LGBTQ+ healthcare delivered in a safe and caring environment. Welcome, Dr. Settle.
Hey, thank you guys. I appreciate you having me. So we're going to talk today about culturally competent, effective communication with cancer screening among the LGBTQ plus population. You can go to the next slide. Thanks. So some of the associated risks and barriers to care. People that identify as lesbian, gay, bisexual, transgender, queer, or questioning, they have screening needs, similar to the general population. The problem is the receptiveness and the barriers to care are there that the general population doesn't have to deal with. A lot of times, the things that we take for granted when we go into our physician or provider and talk about, they don't feel open to that. I mean, as terrible as it is to say in the year of 2022, there's still a lot of people that take issues and have these problems with the LGBT community. And certainly when you're going to your provider, that's not what you want to have, and you don't want to find that. If they feel like they have to hide their true identity or their true self, then they're not going to be open and share their needs as openly. So that's very important. Studies have found that there are lower rates of screening among this community, although for, some cancers may be significantly higher for this population. Things you want to think about are like HPV and rectal cancers and things like that we need to be aware of. And even if people are doing gender affirming care, we still need to remember things like chest exams and things like that. So those are things we need to think about. Next slide. So the role of the healthcare provider is to ensure effective screening when it comes to cancer. You want to build, number one, with the population is you want to build a positive rapport, an accepting environment. You want to be very warm and welcoming. It's easy to identify if you have issues when they come in and you're sitting there with them, or judgmental attitude. So you need to be your authentic self, and you need to make sure when working with this population that there's true acceptance and that is able to be portrayed. So you want to make sure that you have strong communication. You want to sit down with the patient. You want to look them, eye to eye if they're comfortable with that, and really convey that you care about them and that it's a safe environment for them to share with you. You want to do the positive engagement and empowerment, provide logical and proven information. And of course, emotional support is needed, and you want to be their advocate for sure. Use accepting terminology. Again, you want to say if you have someone transitioning from female to male, they're still going to need chest exams. So you want to make sure that you say chest, not breast. You want to be cognizant of the terminology that's most accepting and is best for them. Next slide. You don't want to be afraid of open communication. You want to be open and non-judgmental, and it's okay sometimes. I had to learn a lot of this with this program. It was something, the EquiHealth program that we have here at West Virginia Health.Right is greatly needed. We had a lot of people that were traveling to Columbus and other places to get gender affirming care or get care that they felt was more accepting. I hate to admit it, but sometimes Charleston, West Virginia, or West Virginia as a whole is not always the most progressive area. So a lot of people were feeling like they had to go outside the area. And we have people that come, that are homeless and that come from other cities. And you can imagine if you're in the middle of gender affirming care and you suddenly find yourself homeless and you're in another city, and your identity is tied to that. And then suddenly you're without those treatments, and what do? People become very desperate to buy things online. We've had people come in that thought they were taking hormones and they were actually taking like blood clotting medication. So it's really bad horror story. So very much needed, but I had a lot to learn, and made sure that in preparing for this program that we had everybody at the table and involved. We wanted to make sure we had good representation from all aspects of LGBTQ plus community, and that when we put the clinic together, that it would be something that really showed the heart of our clinic and that we cared. So you want to make sure you use open body language and follow the patient's lead in terms of eye contact. You want to look up from the screen and allow them to respond and ask questions. It's not, as a provider, a lot of times people get in a hurry and you think that you're just going to tell them what they need to do and they're going to accept it. And you can't do that. You need to sit down, accept questions, and really make sure that you provide a safe place and follow through. Next slide. Again, ensure they're understanding why is it important and what's the desired outcomes. A lot of times people don't understand with the different aspects of sexual contact with LGBTQ that there are different risks, but also to make those risks, just to be blunt, Farrah Fawcett died from a cancer that was rectal cancer that was tied to HPV. So we need to also make that understandable that, it's a condition that can affect anybody. And so we need to make sure that people understand that this is okay to talk about, and these are the risks, and these are the things we need to be checking for. You want to look at each patient individually and try to be as accepting so that they can share, their sexuality and their sexual practices so that you can help screen them for risks. Identify concerns that each patient has individually and not specific to the community, because everybody is so different. A lot of things are so fluid today that you can't just assume what someone's sexuality and their practices are. So it's very important to ask them and let them know that it's a safe place to discuss that. Again, ask the patient to ask questions. That's the most important thing, is to let them know it's a safe place to be their true authentic self and that you're there for them. Next slide. Some of the statistics, I won't bore you with a ton of the details, but history proves that most cancer patients have to correct assumptions made by the provider. So recent studies, if you were out, when you're talking about out, is have you told your healthcare provider what your sexual practices are? 19% said the form gave them a chance. 17% said the provider asked them a direct question. 3% said they someone else told the healthcare provider. 58% said they thought they brought it up to themselves as a way to correct a mistake. And this is how they came out to their providers. You think about how difficult it is when you go in to see a healthcare professional, think about women having babies and GYN exams and all this, and to sit there and have your healthcare provider assume your sexuality and how do you broach that subject. So it's very difficult. Next slide. A little bit more about EquiHealth Program. It's an all-inclusive LGBTQ plus specific clinic inside of West Virginia Health, right? We treat this population every day, but we wanted to set aside a specific time once a month to surround them basically with love and acceptance. We do a support group. We have people specific that are trained and do treatment for gender affirming hormones and everything. And everybody that's there is really married to the cause. And we really try to make it an accepting place, and it's growing. We didn't realize how big the need was until we started having it, but the clinic is growing. So we're really excited about that. But it focuses on all the needs. So we do vaccines, cancer screening, contraception, sexually transmitted illness prevention, testing, treatment, HIV, pharmacy access. Those gender affirming hormones are very expensive. PrEP, which is a big thing. PrEP is the drug that helps prevent HIV infection. So a lot of education there. And it's amazing how many people don't know about PrEP. So we really try to educate there. Again, the gender affirming support, specialist referrals, behavioral health, substance use treatment, counseling, and support groups. So HealthRight is pretty much a one-stop shop. I call it like the NASCAR of free clinics, where we pretty much try to do wraparound services for everything. So that access into the clinic gives them access to everything that we offer here. Pharmaceutical, behavioral health, health education, We have a dental clinic, an eye clinic, and again, through grants and hard work, we really try to provide everything free of charge. There's nothing in our clinic that the patient pays for. We do bill for Medicaid if they have it, Medicare if they have it, and if they're uninsured, then that's what grants are for. But we made a decision when the Affordable Care Act came to be that we would never let reimbursement, navigate care or direct how we care for people. So today we're a free and charitable clinic, and basically it's uninsured, Medicaid, and Medicare. And again, we don't charge the patients anything. So this is just another avenue that we feel is so important, and a gap in care that we're trying to fill here in our city and state. Some resources if you want to look some of the information up.
Dr. Settle, thank you so much. We do appreciate your presentation today. We have time for just a few questions. So I'm going to invite all of my panelists to come back on with your camera and microphone. And I'm going to start, Chastity Washington, with you. We have a question. If you could please elaborate on your interpretation or translation services and how they work.
Yes, hi. So in translation services, translation usually means a written document. Interpretation is live language interpretation. So we at the medical center have an interpreter department. They are very overworked because we, again, are a large academic medical center. So what we were able to do is to actually hire bilingual staff and then send them through medical interpreter training. So that allows us to be more flexible when we need that interpretation on the mobile unit or in the community. Again, they are native speakers, but then they also go through that medical interpreter training. We find that very, very valuable. So again, we use the interpreter services within the medical center, and most medical centers have that, or a language line, or a MARTI, which is the video screen where you can bring someone in. But we tried very thoughtfully to hire individuals that spoke the top languages in our catchment area and make sure that we provided them the services and the training to be able to do that language assistance.
That's great. Thank you so much. I appreciate it. And I think the next one is also for you, Chastity, if you could stay with me for a moment. And this one says, I am flabbergasted to learn that patient navigation costs are not reimbursed by insurance companies. Is that true for Medicare and Medicaid covered patients as well?
Correct. So patient navigation, in the sense of true patient navigators, which does have a certification now, is not reimbursed. So community health work is sometimes confused as patient navigation. That is in a reimbursable model through certain pathways, but cancer is not a pathway for that reimbursement model. Medicaid, Medicare had what they called patient navigation, which I think has confused people. They had a bunch of money where they hired navigators, but those navigators were specifically hired to enroll people in the marketplace plans. So I think that's where some of the confusion might come in. Those navigators were specifically hired to enroll people into the insurance coverage. They are not navigators in the sense of navigating people through the continuum of care. So I know there's been some bills put into place. I know that the American Cancer Society and the National Patient Navigation Roundtable is working on that. There are CPT codes for some of the services that navigators provide. However, the insurers are not recognizing navigation as a provider, or a navigator as a provider that can be reimbursed for that.
Gotcha. Thank you very much. Appreciate that. The next question is for Dr. Trappel. We know that persons of color have a higher diagnosis rate. Why are they diagnosed at younger ages?
Mm-hmm. That's a great question. And I think we don't know the answer yet. I have asked a number of my colleagues who are genetic epidemiologists, and I think this is a space of exploration. Again, I said, I always ask why, and no one can give me a good answer yet. So I think this is another place, but again, without having that cohort of men to learn from and who are engaged in the research, it's an unanswered question. I think, though, there would be agreement that there are likely interactions between social environment and biology that really lead to this earlier age of diagnosis across many cancers.
Thank you, Dr. Trappel. Appreciate that. Let me ask this question to you, Dr. Settle. It'd be helpful to learn more about who asks you and your patient about sexual orientation and gender identity? The nurse, the registrar, are the questions sent to the patient before the visit, and how are they answered and documented? Do they go in narrative note or in discrete fields in Epic or in another EMR platform?
We use the Athena Health, and we have really tried to update all of our questionnaires and patient intakes. That's something you really have to be on top of in terms of terminology. And again, I'm not an expert, so we have great partners in Covenant House and Fairness, West Virginia, that a lot of times we'll show them a form and say, hey, will you look at this for us? Is there any issues with the wording or the terminology that we're doing? So we have specific information that's updated that'll ask questions. Of course, we give the liberty if people don't want to say, but it really begins early in triage. Again, with EquiHealth, we have people that identify as LGBTQ that are there and have that conversation. That continues on into the exam room with the provider. And as people become more comfortable with you and they see your true intent, they're more open to share everything, that there's always opportunity for open communication and for them to share. So, and then that information is documented in our Athena Health. And we have certain areas like behavioral health notes and things that are locked off to only like need to know basis and those that do it. But it's just integrated as part of care. We try to make it like every visit, every time.
Great. Thank you, Dr. Settle. We appreciate it very much. And I hope that Reverend Albright, you're seeing you're getting a lot of love and a lot of connectivity in the chat. We appreciate it. Thank you so much to all of our panelists. That'll conclude the panelist portion of our program, but we are so grateful that you shared your expertise and your stories with us today. Thank you. Let me introduce to you our next speaker. This is Kate Tullio. We're going to hear brief updates from several of our partners. Kate is the Director of Health Equity at CareSource. She is also the Health Equity Committee Chair for the Ohio Partners of Cancer Control. Kate, welcome.
Hello, thank you so much for having me today. You can go ahead and advance to the next slide and the one after this. So as Deb mentioned, I am the chair for the Health Equity Committee for Ohio Partners for Cancer Control. If you live in Ohio, and many of the panelists today and folks that I know are on are members of OPCC, but if you're not familiar, Ohio Partners for Cancer Control is a collaboration of organizations, programs, and individuals that are dedicated to reducing the cancer burden in the state of Ohio. What that means is there are amazing partners from just about every sector, whether that's healthcare, providers, individuals, advocacy groups, private business, that work together to talk about cancer-related issues. And what my theme is today around this is what a great platform that is for advancing health equity, in that we all have to work together. So OPCC was developed through, ODH is kind of our mothership here. We develop, implement, and evaluate a comprehensive plan to reduce cancer in Ohio. And we have statewide leadership and coordination to be able to do that. We meet 3 to 4 times a year in person when we can, which we miss very much, but the virtual option has always been available and is a lifesaver, both in COVID and non-COVID times, to be able to collaborate with some very busy people all across the state. Next slide. So like I mentioned, this is a really diverse group of people all across the state. So there's community-based organizations, there's federally qualified health centers, there's government, there's universities, there's people and patient advocates that are just so passionate about this topic. It is open to anyone, and that has served as such an amazing foundation for our group. What do we do at these meetings? Like, what is the value of OPCC? So in addition to the state cancer plan that I'll talk about a little bit more, there's a lot of information sharing. We have amazing guest speakers that talk about not only cancer data, but other issues that are relevant and important to the cancer sphere. We work together to identify what shared priorities should be. We work to advocate. So we talk to, ACS has been a huge partner, as ACS can, around cancer advocacy, what's kind of going on through the legislature as well. We network. I think that's been one of the most valuable, is just meeting others doing this work and sharing best practices or experience or elevating our work across the state. And we educate. So trying to figure out, how we can educate not only the organizations or groups that we work with and bring that back. But the state at large, how can we make education for patients, for example? We do have a health equity subgroup. It was established, if I think I have my math right, in 2019. We had a couple in-person meetings before we shifted to COVID and set some goals. We just, at that point, were a really passionate group that wanted to make sure we promoted health equity. Next slide. So we talked about this cancer plan. It is amazing. If you go to the OPCC website, you will be able to see it. It is a new plan for the next 10 years. We outlined objectives to meet and the strategies of how we will do that. This is Ohio's 4th cancer plan, and it really is a blueprint for action. So really setting some specific goals of how to eliminate all sorts of issues across cancer or ameliorate them, and specifically how we're going to look at health equity in some of those goals. So there was a specific emphasis as we started to write these on how we make sure a health equity is represented across all of the categories. Some of the categories you'll see if you look at this cancer plan include primary prevention, early detection, quality of life, but starts to get really specific too. Like, what does that look like within breast cancer? What does that look like in pediatric cancer? What does that look like in survivorship across the entire spectrum? Next slide. I just want to talk a little bit about how we made sure health equity was involved in each of the objectives and strategies. So, if you look at it, it looks like a lot of text, and I guess you can't see my mouse, but that first kind of paragraph shows like what an objective looks like and what strategies look like. And what we did as a health equity subgroup is we just kind of started to research other best practices from other states. So what do other state cancer plans do when it comes to health equity? There's a huge variety. Some states don't have a ton. Some states have so much health equity, and then how they address that or call that out. As a group, we decided to talk about how do we want to do this? Do we want to have our own standalone health equity objectives in our cancer plan, or do we want to integrate health equity into each subject area? And overwhelmingly, people said, let's integrate it. There certainly should be standalone health equity objectives, but health equity should be in everything that we do. So let's integrate into each of these objectives and strategies. So we identified a health equity, what I will call champion, to work within each subgroup to help develop objectives, to really kind of serve as a subject matter expert, to consult, to make sure that health equity was represented, to help do some research if we needed that. And the best part was so many of our health equity committee members were already serving with some of these other subgroups that were writing these. So it was a really natural integration to make sure. There was a lot of diversity, I would say, in how each of these subgroups then decided to integrate health equity into their goals. So in this first goal you see here, this is an example with cervical cancer. We had some amazing data already about disparity as it comes to health equity. For example, you can see the data here that already exists by different racial breakdown, and then what those strategies were to identify and ameliorate those health equity disparities. So develop a low-level literacy educational materials in various language to address those language barriers to understand abnormal results in diagnostic care. So really, really specific here, not only in the data, but in the strategy as well. That's not to say, for example, another one was around understanding financial burden in cancer patients and how we address health equity there. So we still had goals. We don't have a ton of data necessarily in this space, but we do have goals to convene a diverse group of experts and a diverse group of community members to understand how telehealth impacts them, their access to telehealth, and then what recommendations are. So there's areas throughout the state of Ohio that have very little access to broadband, rural and urban. And so how do we address telehealth in those kind of communities as well? Next slide. So we have it in the plan. Now what do we do? So we have the next 10 years to make sure that these health equity goals get reached, right? So as a group, we continue to monitor health equity within these objectives and these strategies that we wrote. We're going to continue to support these groups as they implement them. How are we meeting these goals? What do you need help with? How can we help? We will also offer education, new literature to some of these groups, or consider objectives and strategies that maybe didn't have a health equity call out initially, and help provide some data there as well. Our health equity subgroups continues to meet. We always meet outside of the regular OPCC meetings that I mentioned, are 3 to 4 times a year. And we do that so that our group members can stay integrated in those other subgroups and not feel like they have to choose between. So they're always immersed in health equity, and they're always immersed in the work that they're doing in their subgroups as well. We use that subgroup for conversation and sharing best practices. And I also mentioned we wanted to set our own standalone goals as well. For 2022, we've decided that's going to be data and data collection. We have such an exciting plan to try to identify the best practices for collection of data around race and ethnicity, SOGI, and social determinants of health. We want to work as a committee to make recommendations for how to best collect this data. And then we want to create education for providers and patients about the importance of collecting this data. We've had such amazing conversation, and we really feel as a group that represents so many diverse organizations and people across the state of Ohio, something like the recommendations that we have could be really, really powerful. So it's just an amazing group. If you're in Ohio and you're not already a member, I highly recommend you join. Thank you so much for the time. That's all I have.
Terrific, Kate. Thank you so much. We do appreciate your presentation today.
Oh, I lied. I have one more slide.
Oh, you go right
I'm so sorry. I'll go really quick. I'll go so quick on that slide. I'm sorry. All I wanted to say is it can't be achieved alone. You know, we talked about the data and what we have and how we measure it, but we all have to be in it together. And we need to make sure that health equity is in everything we do all of the time. That's all. Sorry.
Perfect. Thank you, Kate. We appreciate it very much. Next, we're going to hear from Lauren McCauley-Hicksonbaugh, Program Manager for West Virginia University Cancer Institute's Mobile Lung Cancer Screening Program, and from Abby Starkey, Program Manager of WVU Cancer Institute's Mobile Mammography Program and Program Coordinator for the Mountaineer Health Initiative. Welcome, Lauren and Abby.
Thank you. So we're really excited to be here. Thanks for having us. We're excited to talk to you about our project to increase cancer screening among the LGBTQ population in West Virginia. I'm Abby. My coworker Laura and I are going to present together. So primarily, we both, as I've said, we both work for the WVU Cancer Institute Mobile Cancer Screening Program. I'm primarily manage Bonnie's Bus, for those of you who have heard about it, and Lauren primarily manages the new mobile lung cancer screening unit we call Lucas. In addition, the work that we did for this PSA, multiple PSAs actually for this campaign, we did as members of our state cancer coalition, Mountains of Hope. Lauren is a member and former manager of the coalition, and I'm currently the chair. You can go to the next slide. So we just want to start with our why. So we have a passion to serve this population, and AIM 13, as well as several other of the aims in our 2020-2025 cancer plan, included a health equity campaign. The nature of the work that we do and where we do it, the only state, West Virginia is the only state that is fully encompassed by Appalachia. Most of the work that we do is considered health equity because of our rural nature. But we had yet to really focus on this population. Many of you may be shocked and may not know that West Virginia actually has the highest rate of people 17 and under who identify as transgender. This, as most of you do know, I'm sure, the LGBTQ population has higher smoking rates than the straight and cisgender counterparts. The Human Rights Campaign, the largest LGBTQ advocacy group and LGBTQ political lobbying organization in the United States, lists West Virginia as a high priority to achieve basic equality, meaning our state does not have basic laws to protect those that are LGBTQ. Additionally, West Virginia's state health plans, including the state Medicaid policy and PEIA plans for state employees, explicitly exclude transgender health coverage and care. No explicit policy regarding transgender health coverage and care. So we're behind, which is why this was really important to us. So we recorded several PSAs and we started airing them on Memorial Day with primetime spots that ran until the end of June. The results you can see here are cumulative of the 5 PSAs that we created. you can see that television has the largest view per delivery method. However, we know that streaming and social media, that participants interacted and watched the entire clip. We can tell through the streaming sources how much of a clip someone watched versus television. We just see that it aired in your home. I don't know that you were sitting there. I don't know if you walked away. I don't know if you fast forwarded, but you can't do that with the streaming service. You're forced to watch it. So with the streaming services across all 5 PSAs, we reached 84,375 people with a 98% completion rate. Social media, we reached 82,000 people with 443 clicks. There was a link available to learn more, and 443 people clicked on the link. For television, our average daily reach was 447,000 viewers. Several spots were bookends of local news broadcasts. They were played on TV from Memorial Day weekend with primetime slots on June 30th. I don't think I covered, but we started this in June because it's Pride Month. That was very important to us. We ran a second campaign concentrating on lung cancer. 2 of the 5 PSAs concentrated on lung cancer. Our speakers had something to say about lung cancer. So we ran again in November. We targeted cities within 13 West Virginia counties that have the highest lung cancer incidence rate. Those were played on streaming services from November.
Sorry to interrupt you, Abby, but will you advance the slides? There we go.
Oh, they did. Oh, sorry. I usually advance my own slides, so this is new to me. Thankfully, Lauren caught up. Okay, can we advance one more? So again, we utilized 2 of the 5 PSAs in November to talk about lung cancer, targeted 13 counties with the highest lung cancer incidence rate. Our total impressions were 35,000, over 35,000 with a 92% completion rate. These circles you see on this map indicate the views per geographical area. Move to the next slide, and I'm going to hand it over to Lauren.
Thanks, Abby. So one of the things that makes our coalition successful is partnerships, and that was no different with this project. Partnerships were the key success here. And you already heard from Dr. and Reverend, how about that, K Albright. And she was actually one of our participants, and her organization partnered as well. But each of our partners was really excited to participate and collaborate with us. And with these partnerships, we almost doubled our original budget when we started out, which made it more possible for us to have additional participants within the PSAs, and you're going to get to see those here at the end. And then we also were able to afford a professional production company, which is part of the reason that you saw the success that you did with the numbers. The production company made it wonderful and was able to showcase everybody and their story in brief snippets, which were really great. We had bi-weekly meetings with this group while working on the content and the production. And then we met with 84 Agency, the production company, which is an LGBTQ West Virginia owned and operated company to film and edit the videos. Next slide, please. So some of the lessons learned here, recruiting of the video participants was the most difficult part of this. It shouldn't have been, but it was difficult. We had to call out storytellers throughout all of our networks. And ultimately, that didn't really work. What worked was personal connections that we had with each of our wonderful participants. Every one of them had a unique perspective of how the cancer continuum affected their life. As you watch through these stories, you'll learn through many of the agencies here today that we're really doing good work in West Virginia for the LGBTQ population, but we really have a long way to go as well. Next slide is Rosemary Ketchum, and she'll tell you just a little snippet about her story. And then when these slides are shared with you, you'll also get the opportunity to look through the rest of the PSAs.
Cancer screenings are critically important, we all know, but in my own life, they have been incredibly important. My name is Rosemary Ketchum. I am a member of Wheeling City Council here in the city of Wheeling, West Virginia, and my pronouns are she, her. In July of 2019, my mother was diagnosed with stage 4 breast cancer. And I can only imagine if we had received a cancer screening 5 or even 10 months earlier, how the trajectory of her healthcare journey could have changed. As an LGBTQ+ person, having access to quality and informed healthcare is really important, particularly in regards to healthcare cancer screenings. As a trans person, I know that I need to receive both breast cancer screenings as well as prostate cancer screenings. Receiving safe and affordable care is life-saving. Take pride in your health, West Virginia. Get the screening your body needs.
So that's just one of several that we produced and put out for everyone to see. Working with Rosemary and the rest of the team was great. And I hope everybody will take a moment and check those out and share them on your networks. And hopefully we can get more people screened and taking pride in their health.
I do want people to know, like Lauren said, it was very, very difficult to recruit. And ultimately they were people that we knew, except for Rosemary. And I tell this so that, like, to inspire other people, because I was nervous. I sent her a message on Twitter because I follow her on Twitter. So slide into people's DMs, like, it's not unprofessional, it's fine. She responded a week later, gave me her personal cell phone number, and I called her up, and she was great. She was great to work with. If you've never had the pleasure of Rosemary Ketchum, I hope that you do. She is an inspiration. But she was, for us, very important because she's the first elected West Virginian who is openly trans. And so that was very important for us as far as representation goes, for people to see.
Okay, thank you both so much. We do appreciate your presentation today and love the video. Thank you for sharing that. And I know that you said you have more, so I'm sure people will reach out to get the address for that. Thank you so much. Our next partner is David Brewer. Mr. Brewer is the Director of Clinical Service and Quality Improvement at Heart of Ohio Family Health Centers. Welcome, Mr. Brewer.
Thank you. So Heart of Ohio Family Health Centers is a federally qualified health center with 5 clinics in the Columbus, Ohio area. And we serve people from very diverse backgrounds. Something like 80% of our patients are minorities. And of those, greater than 50% are African American, and about 15% are Hispanic. And as you can see, we have been working on colorectal, breast, and cervical cancer screening. We received a grant through Pfizer in partnership with the American Cancer Society. We have implemented a program of patient navigation. And for health equity, I think a big piece of that is tailoring interventions to the individual, those individuals of different backgrounds, and patient navigators allow that opportunity because the education and the discussion and the methods of convincing patients of the need for these screenings is so dependent on the individual, and adapting that to the group that we're trying to make improvements for. And so we hired 3 patient navigators, one for colorectal, breast, and cervical cancer screening. Of that group, one of them is a community health worker who can help with applying for insurance, in addition to the normal patient navigation, and also helping with social needs such as transportation, housing, and all of that may, it's hard to think of getting a cancer screening when you don't have a home to go to at night. So as a part of that individual education and assistance, completing outreach, patients that have a fit test ordered for colon cancer screening, but don't bring it back. So calling them, reminding them, mailing them a new test if they lost it, And we've done a combination of that outreach, both for people that already have tests ordered and helping them navigate that, and then calling patients that don't have tests ordered and helping them navigate that situation. And then tracking, making sure that they follow through on getting that screening. And then on the cervical cancer front and breast cancer screening front, we realized that the access, it was difficult for our patients to get in. Cervical cancer screening at our clinics was only completed at well woman visits. And those are 30-minute visits at our clinic. So we can only fit so many of those onto the schedule. So we also realized that at our practice, where we have both primary care and women's health care, that our primary care providers were deferring to the women's health providers, which further reduced access for cervical cancer screening. So they were referring all of their PAPs, and then the women's health team could only do so many. So we trained more providers on completing cervical cancer screening, adjusted the schedules to allow more patients to get on, and we're able to provide better access, as well as doing cervical cancer screening separate from well woman visits and being able to decrease some of those to a 15-minute visit. And then on the mammogram side of things, patients in our population have difficulty or discomfort in going to the large hospitals to get this service. So we have arranged for 30 mammogram buses to come per year and give patients more local access at our clinic to those mammograms, where they're more comfortable coming. They know that we have interpreters, and they know it's a place that they're welcome. And we also provide gift card incentives for the mammogram bus to ensure that patients come. And the results speak for themselves. You can see where we were in August of 2020 compared to November of 2021 when we last pulled our data. We've made large strides in each of the 3 areas of cancer screening, and we're just getting started. We had a little bit of turnover in those patient navigator positions early on, so we have not even seen the full impact of this intervention yet, and we're excited to see how it goes. And that's it for my presentation. Any questions?
That's terrific, Mr. Brewer. Thank you so much. We do appreciate it. Please keep your eye on the chat for questions that pop up. But for right now, we will move forward. So we appreciate to each of our community partners a big thank you. And we'll move next into Tracy Wheat. Tracy is the Managing Director for Health Equity for the American Cancer Society. Tracy, as Managing Director, helps oversee the work that's aimed at communities to fight cancer by addressing the underlying causes of poor health and helping to ensure everyone has an opportunity to be healthy and cancer-free. She leads a Robert Wood Johnson Foundation grant and manages a highly talented team focused on embedding health equity approaches in the American Cancer Society mission priorities to reduce the unequal burdens of cancer outcomes. As an Ohio native, Tracy has 20 years of experience working in federal and nonprofit public health agencies and organizations, to name a few: the CDC, the US Senate, the YMCA of the USA, and the National League of Cities. She's played a pivotal role in the development of the nation's Healthy Communities movement in using policies, systems, and environmental strategies. Welcome, Tracy. Thanks for joining us today.
Thanks, Deb. It's great to be with everyone. And I'm so grateful for the invite to be on this session with so many talented speakers. I wanted to give a shout out to my ACS colleagues and also Mary and Ella for your leadership. We can't do our work without great volunteers and partners. And I also want to give a shout out to our partners in Ohio and West Virginia. It's been echoed several times that we need to collaborate and work together. We can't go at it alone. And you'll hear in my slides various things that are reinforced. On the next slide, I thought I'd take a moment to share what ACS and ACS Can believes, which is we believe that all people should have a fair and just opportunity to live a healthier life, healthier life from cancer, regardless of how much money they make, the color of their skin, their sexual orientation, gender identity, their disability status, or where we live. And for us, it's a moral imperative if we are to achieve a vision for a world without cancer. And in order to reach that vision, we need to do a better job of listening to the experiences and perspectives of people who've been marginalized, their caregivers, and their communities. And we can't do this as an afterthought, which I think a lot of people have shared already. We really need to make sure that people are foremost engaged with us, and we're listening to them throughout our journey with them. And it's been great listening to the awesome examples that have been shared in this session that are happening in Ohio and West Virginia. On the next slide, I thought I'd share a few resources that might be helpful to your efforts or reinforce a lot of the hard work that you're doing. A lot of people within the US and internationally, globally, know us for our research. We continue to put out the latest evidence and data to help support not only where we should be moving as an organization, but as a society and with our partners. A few years ago, we published a research article that looked at understanding and addressing social determinants to advance cancer health equity. Just last month, we published an update on the status of cancer disparities in the US. And in the next couple of weeks, we will be releasing an updated cancer facts and figures that's focused for the African American and Black community. And we will be more deliberately calling out things such as racism, medical mistrust, and other drivers of cancer outcomes in not only that cancer facts and figures, but as we continue to put out our research, really being more explicit and intentional in sharing that information. We also have data briefs that are called Facts on Our Fight that range a whole host of topics, whether it's lung cancer, whether it's the Hispanic Latino community, the LGBTQ community, or how cancer has been impacted by COVID. It does a really good job, or these resources, I should say, do a really good job of outlining not only the data, but also what ACS and ACS Can are doing to address these disparities. Last fall, we released an inclusive language and writing guide. And within that, it's the preferred word choices by various populations to communicate accurate, respectfully, and consistently word choices and uses when it comes to working with and being respectful of different populations. It's a great resource, and we encourage you to use it in your efforts as well. On the next slide, I thought I'd share another tool that we've been using for the last several years that's really allowing us to check our own practice within ACS and ACS Can, and it's our health equity guiding principles. You'll see that there are 3 areas listed on the screen: people, place, and partnerships. And there are concepts that we are thinking about as we do our work in order to ensure that everyone has a fair and just opportunity to be healthy and cancer-free. So for example, when we think about people, we should be asking, how are we collaborating with community members throughout this work? When it comes to place, thinking about things such as, are we really doing our own part to understand the community's historical, social, cultural, and economic context that's happening in their community? Or are we really thinking about and being action-oriented on addressing the structural and social determinants of health? When it comes to partnerships, are we working with different sectors who represent maybe populations and skills and assets that might not be our strengths? So how can we collaborate together? And how are we preventing and addressing unintended consequences so we're not causing harm? So this is another tool that might be helpful for your efforts, either as coalitions or as organizations, or even as individuals as well. On the next slide, I thought I'd share a little bit more about what we're doing when it comes to storytelling. Again, underscoring some awesome work that's been shared already on this call. We know that storytelling is critical to helping people understand. And these are just a couple examples illustrated on the slide in which we are leveraging and utilizing the perspectives of people's experiences when it comes to addressing cancer. So whether it's from frontline workers or it's from people who have specifically been impacted. On the left is one of our frontline workers in Philadelphia, who is a clinician who is a phenomenal, dedicated individual person who's really looking at how we can increase access when it comes to clinical trials. In the middle picture, there is a woman who has benefited from some of the grant funding that we've provided to a health system in New Jersey. And on the right is a video that we developed that highlights the story of two women, how they both grew up together in the same neighborhood. They both ended up being diagnosed with breast cancer, but they had drastically different experiences. And we've also included a discussion guide that will help either an individual or a group of people really reflect on the drivers of health and what contributed to what was happening. That just isn't specific to this example of these two women, but is happening throughout the country. On the next slide, I wanted to share a little bit more about where you can access some of this information. The American Cancer Society has its cancer.org health equity page, where we have information that speaks to some of the gaps in cancer outcomes, but also speaks to some of the things that the organization is doing. We're in the process of updating that information, and as we work through information or more data or activities are available, we try to update that. The second website, which is fightcancer.org, is our nonpartisan advocacy affiliate, ACS CAN's website, again, where you'll be able to find some really awesome examples of what our colleagues in the legislative and lobbying side of the organization is doing. And last but not least, we also wanted to create a health equity YouTube playlist and channel in which you can access things such as the video that I referenced and other videos and materials that are helping to illustrate what we're doing within the American Cancer Society. And I will say, you know, I think we've all been on a journey, and that's true for the American Cancer Society. And Marianella mentioned that the organization has been very passionately and dedicated for several decades now in addressing the disparities that exist. And we're trying to do our part to identify, you know, how we can strengthen the work that we do, be more intentional, and really truly listen to the experiences and the perspectives of different populations that are being impacted by cancer. That concludes the rest of my presentation. I wanted to make sure that we had time for questions as well. And I know that not all of the resources, like I think our data briefs aren't online. And so if you want to reach out to your ACS staff partner, I can make sure that they have all the resources and can share them with you as you see fit. It might be a lot of information, so it might be helpful if you inquire and ask what specific resources you think would be helpful. So we're happy to contribute and share. And thanks for being a partner with us too. We can't do this alone, and we're grateful for the passionate and dedicated people who are addressing this from different perspectives. We're in this together. So thank you.
Tracy, thank you. We very much appreciate your time and your presentation this morning. I wanted to stop just for a moment and answer a couple of questions, ask a couple of questions so that our panelists could maybe answer them from our community partners. First one, Mr. Brewer, if you're with us, I wonder if you could come back on camera and we'll ask the first one of you. And that is, you'd mentioned that a number of your patients are homeless. How do you contact patients for follow-up care? What are your strategies and methods?
We have found that many of our patients who are homeless still own cell phones. We are still able to communicate with them through that way. We also have a process by which when patients have an open mammogram referral and we haven't been able to get a hold of them and confirm that they've been connected to get that referral, our patient navigator gets a report of everybody coming in the next day. So the day before, they'll get a report of the next day of who is coming in and has a pending referral. So then they can, talk to that doctor and make sure that the patient gets connected with them on that same day, and essentially work things out while the patient is in the clinic.
Fantastic. Thank you so much. And a follow-up question, is there any portion of your electronic medical record that assists with the process?
Yes. So our medical record Allscripts has a referral tracking system where we can mark the various stages that a mammogram is in the referral process, or a Cologuard, or a FIT test, or a colonoscopy order. And we have a process where we document each step of the process, like the fax was sent out, the patient was communicated with, the date of the appointment is this, and then we track that depending on the urgency of that referral.
Terrific. Thank you so much. If anyone has questions, feel free to put them either in the Q&A or the chat. At this point, we're going to move forward, but we do appreciate all of our partners for presenting this morning and for your partnership with us. So our next presenter is Leo Almeida. Before we begin, though, we will do one more poll. So you'll see it pop up on your screen, and we would love to know, how do you work to achieve health equity in your practice or place of work? Please check all that apply. And if you're completed, hit submit. And we'll give you just a moment to do that before I introduce Leo. Okay, while you're completing that, again, you can check multiple when you hit submit. I will go ahead and make introductions here. So we're next going to hear a few updates from Leo Almeida. Leo Almeida. Leo is the Director of Government Relations for the American Cancer Society Cancer Action Network. Welcome, Leo.
Thanks, Deb. If you want to go to the next slide. So it's good to be with everyone this morning. Wanted to quickly do some updates on ACS CAN and our involvement on federal advocacy and state policy, and also some upcoming events. I'm going to cover Ohio first, and then also cover some of the work that our team in West Virginia is doing. So on the federal side of things, I'm sure all of you have been hearing a lot about Build Back Better and have been following that in Congress. The House did pass this late last year, but has stalled in the Senate, at least for the time being. We've been hearing that things will be picking back up on this, and they're hopefully going to reach some kind of deal in the near future, but it might not be till end of February or even into March before we see some movement on this. But during that process, we will be continuing to advocate for Medicaid expansion, expanded subsidies through the ACA exchange, and capping out-of-pocket drug costs for Medicare enrollees. Additionally, we are always looking for opportunities to advocate for funding for cancer research and prevention programs, and that's especially true right now as we continue to talk to legislators in Congress about the appropriations bill. The 2022 funding bill was postponed yet again. We are currently under a continuing resolution until February 18th, which means that basically everything that the federal government operates is flat funded under the 2021 amounts. But as, again, those conversations continue, we'll be looking for opportunities to engage around increased funding for the National Breast and Cervical Cancer Early Detection Program and funding research in different areas. I'll go to the next slide. At the Ohio State House, we did have some success at the end of last year. The telehealth services bill was passed. That's House Bill 122. That's something that we had been advocating for a while. Our position on this was, especially during COVID, this was a great opportunity to expand telehealth services for cancer patients and survivors or others who are immune compromised, so that if they could avoid going into a doctor's office and still get adequate care from their doctors through different appointments online, that was a great opportunity for them to keep them safe. However, as we talk about health equity today, there's still some concerns here. Kate mentioned some about telehealth services earlier, and we are certainly, aware of those. We think a lot about, this is great for people who might not have transportation to get to a doctor's office for appointment, but then at the same time, not great for someone who doesn't have access to the internet at home. We've heard stories from Southeast Ohio where there's a lot of broadband issues where folks who want to utilize telehealth have to drive to their public library and take their appointment in the car, so that way they can utilize the library's Wi-Fi. So, while this is a great bill that we got passed, still a lot of work to do in this area. Another issue we continue to follow is House Bill 218 or any of the other anti-vaccine bills that have been introduced and continue to pop up now and again. We remain strongly opposed to this. It'll definitely be an ongoing issue throughout the year. Our position is really, twofold. One, that the more people that are vaccinated, the easier it is to control the spread of COVID and to hopefully decrease the chances of a cancer patient or survivor contracting COVID. The other aspect that's really important to us is that we have an internal policy at ACS for staff being vaccinated, especially those staff at the Hope Lodges, one of which is in Cleveland. Those places are intended for cancer patients to utilize, and we want to make sure that all those who work and visit that place are vaccinated in order to protect our cancer patients. Another bill that we have been following for a while is House Bill 135, the copay accumulator bill. This bill passed the House Health Committee back in March unanimously, and unfortunately has not been brought up for a full vote of the House. Typically, we wouldn't see this. Typically, a bill that makes it quickly through committee with bipartisan support moves along pretty quickly and easily. But this, for some reason, has gotten hung up. So we hope to try to figure out what's the holdup and get this done. We do feel like, the fact that it's the start of a new year and everyone's insurance has restarted in terms of meeting your copay and minimums and things like that, will hopefully encourage legislators to recognize that this needs to get done. For those of you who don't know, this bill essentially would allow patients who have copay cards or some kind of manufacturer discount would be able to not only use that at the pharmacy to make their prescriptions more affordable, but then it would also apply to their minimums for insurance, something that is not always happening depending on what insurance coverage you have. So if we do this, this would be a huge way to help people who have expensive prescriptions like cancer patients and cancer survivors save money in the long run. Go to the next slide. So an upcoming event we have is our Cancer Action Day. So this is our annual lobbying day at the State House. We are looking at March 30th. Right now, we are planning for an in-person event. Obviously, we're tracking COVID numbers like everyone else is and want to make sure we're paying close attention to what's going on. This could eventually be a virtual event. Right now, we're making plans for in-person, but we'll watch that carefully. If you are interested in being involved in this event, we are still recruiting folks to volunteer with us. You can go to fightcancer.org and go to the Ohio page and register through there. And if you're also interested and just want to ask more questions before registering, please feel free to reach out to me. We'll definitely talk to you about this event. And next slide. So moving to West Virginia now, our team has been very active in West Virginia with session starting on January 12th. They're currently working on a significant tobacco tax increase. That's a bill that they have been working closely with one of their senators on and trying to get that introduced. So that's going to be a priority for them. They're also looking to increase funding for West Virginia's tobacco prevention and cessation programs. You know, those programs are very important to states that have high tobacco usage. And so they're really going to be looking for ways to increase the funding and hopefully utilization of those programs. Next slide. As far as a grassroots update for West Virginia, they recently participated in Prevention Day at the Capitol with 41 other organizations to emphasize the need for prevention funding. This is one of their big events and was very successful this year and really draws attention to some of the needs for funding on prevention programs. They are also working on collecting stories and taking action to try to make lasting impacts on the future of West Virginia. This is an ongoing project for them, and they could really utilize your help. But we've heard from other presenters today about, you know, listening and hearing from people who are impacted and their daily lives are impacted. And so this is what they're trying to do, is to collect those stories. So if you personally have a story or know someone who's from West Virginia, there's a link there for how you can share that story. And that's all I've got.
Terrific, Leo. Thank you so much, and thank you for spending some time with us this morning. We certainly do appreciate it. We're going to pause for just a moment and answer another question that's come up in the chat. If I could ask Dr. Trappel, Dr. Erica Trappel, if you would come back forward for me on camera and microphone.
I'm here.
Thank you very much. We appreciate it. So one more question has come in, and that is, do you feel that prostate cancer events are still important and needed to be done by health systems? It seems that many hospitals and practices are still encouraging this, though informed decision-making is a priority and not necessarily happening.
Thank you for that question. I think at this time, yes, all of these outreach mechanisms are still very much needed. I think our approach is one approach to bring it into barbershops, which is a specific location. We're also thinking about partnering with salons, beauty salons, where we can talk with women whom we know are family members of men who might not be accessing prostate cancer screening. I think outreach events that health systems offer are yet another way to go to the community to not only raise awareness about prostate cancer screening, but also to continue to rebuild our trusting relationships with community partners. I think those events are very important, and I think there's no one of these activities that is a silver bullet for addressing any of this cancer screening issues that we've discussed today.
Perfect. Thank you, Dr. Trappel. We do appreciate it, and we appreciate your comment as well. All right, so as we near the end of today's forum, we know that we have been just packed with information, and obviously a number of our speakers have demonstrated that we have a long way to go in health equity through the cancer lens. We have another important message that we'd like to share with you, though. We want to share a little bit more about the H.E.R.O campaign that Marianella Napolitano started us off with this morning. So if we could, let's take a couple of minutes just to hear from voices at work in the community on why the spotlight is critical right now.
In 1966, Martin Luther King said, "Of all forms of inequality, injustice in healthcare is the most shocking and inhumane."
I don't want another 50 years to go and we still talking about the same issue, an issue that can be resolved.
In our fight for a world without cancer, it's clear that the fight is not a fair one.
There's a lot of research that shows that someone's zip code can be more important than their genetic code.
There's no equity in health. It's the haves and the have-nots.
What does equity look like? It's all people having the same outcomes.
I feel like it's more systematic barriers that we were placed in that would give us those inequalities of healthcare.
Despite all the different diverse things that impact each patient uniquely, they all have one common thing. They're trying to beat cancer.
You know you're in for a fight for your life.
I needed someone to follow to get me through this journey, because it's a journey and the journey doesn't stop. And American Cancer Society, they help you with a lot.
We invest in the American Cancer Society because of the great work that they do. Health equity is extremely important and vital to our work as well, and so really our missions align very closely.
Solutions around cancer-related inequities require thinking outside the box. It takes a village to resolve these issues.
Most of it really does come down to socioeconomic, so it's all cultures, it's all people.
Some of these populations are almost invisible. And that's one of the reasons why I believe they continue to be under-resourced.
Myself, I'm from a rural community, so we are definitely underrepresented in the fact that we have one 2-story hospital, and it's got like 2 doctors, and we have to drive to Lexington for pretty much everything.
Nobody benefits from having under-resourced communities in a society. It affects all of us.
Addressing the unequal burden of cancer in all populations has been a core priority for the American Cancer Society for decades, but now we are taking it to the next level.
They're saying, aquí estamos para ustedes. Nosotros los apoyamos. We are here for you. We're recognizing your strength. We're recognizing the fact that you're more courageous than you ever thought you could be, and we will be here to carry you through.
The American Cancer Society is doing so much to raise awareness, and so very grateful because we're having such important conversations about this. This is how we create change. This is how we do something really radically different and change the game with cancer in these communities.
And today we're asking you to join us. No need for superpowers, alter egos, or capes. Just the courage and the will to do what's right.
We do hope that you'll join us in the H.E.R.O initiative through the American Cancer Society, and we're so grateful that you chose to spend your morning with us today. So in closing, we hope that you'll join us for our next virtual forum, where we will be discussing health equity and colorectal cancer. Immediately after this session, you'll be asked to complete the post-event survey. Completion of this survey is required to receive the continuing education credits. You'll also receive a post-event email with a recording of the session and the survey links. While this concludes the program for today, we know this topic goes on. So thank you so much for spending your morning with us, and thank you for all that you're doing to fight for a world without cancer. Have a wonderful day, and thank you.